Well, hello and a warm welcome here. My name is Dr. Syl. I am a doctor from Australia training to become a psychiatrist, and I make mental health education videos with cups of tea. Today we're going to talk a bit about obesity, really a topic that is difficult, common, hard to treat, pervasive, stigmatized, and really, really challenging. But needs to be talked about because it's one of the big killers. And actually, that's where I want to start. I want to start about what kills people. Why do people die? And it's not all about death. It's also about morbidity. So mortality is death rates, but morbidity is disability associated with illness. And not only does obesity result in earlier death, but it does result in a harder life. Things are harder. So, we should talk about it and talk about the treatments. The first thing to say is it's not obviously, it's no one's fault, right? This is a really difficult situation, and we're going to talk about the causes, and we're going to talk about evolution and our genetics and the neurobiology that just makes it such that the human body wants to be overweight. The body wants to have storages of fat that is in surplus of its needs. So you're fighting biology. To not be overweight is to fight biology and psychology because they're both geared towards becoming overweight, and that's why there's such significant numbers of people who are overweight and obese. So, just as a bit of context and perspective, I want to start with a view of human history. And Peter Attia kind of talks about how we have moved from fast deaths to slow deaths. So, let's just say humans have been around for 200,000 years. For 199,900 of those years, we have died by fast deaths, right? That's things like getting mauled by a bloody tiger, trauma, wars, stabbings, and infections. Oh my gosh, infections, massive. So people getting sepsis and dying in a matter of days, and issues in childbirth. These are the things that have killed humans for the majority of history. Okay, and then in the last 100 years, things have changed. We have shifted towards slow deaths. The average life expectancy in 1900s was around 50, and it was really infections that were killing people. Once we got antibiotics, people got to the 60s, and then it was really kind of like heart attacks that were killing people. And then we got statins and treatment for heart disease, and then it was really cancers that were killing people in this, and then life expectancy got to 60s and 70s. And now life expectancy is, 70s and 80s, and that's really neurodegenerative disease, dementia that's killing people. So you can kind of see how we've been kind of getting a decade at a time, but we've plateaued a little bit at the dementias because they're so hard to treat. But all this to say that now the current killers are slow deaths, okay? Things like cancer, heart disease, metabolic syndrome, which obesity is a major factor in, and we'll talk about that, and cardiovascular. Sorry, I've forgotten which ones I said. Let me go through them. So cardiovascular disease, heart attacks, cancer, metabolic syndrome, and neurodegenerative diseases like Alzheimer's. Those are the four big killers at the moment. That's the way that people die most commonly. And my goal isn't to get into medicine and to stop people from dying. I want people to have good deaths and good lives and good health spans. Okay, we always talk about lifespan and people living as long as possible. That's naive, that's simplified, that's superficial. We need to talk about health span, which is living as long as possible with good health. Because, I've worked in nursing homes, I've done aged care rotations as a doctor, and when you are, just staying alive with disabilities, that makes your quality of life horrible. And life is so tough in those situations. So we want to maintain quality of life. It's tough. Anyway, so why are we talking about obesity? Well, it's a major issue in psychiatry, and working on psychiatric wards and charting these medications that can cause weight gain. It's something as a doctor that I need to be really across. It's also something that I want to make a video about for educational purposes for my patients, for you to understand, and that way we can reduce it as best as possible. So I've just got some notes down here, but I guess the first thing to say is we used the word metabolic syndrome before. This is a phrase, or this is a term, a syndrome that it basically captures a couple of different diseases. Okay, it captures high blood pressure, high blood fats like hypercholesterolemia, high triglyceridemia. These are the terms that we use for problems with fat metabolism. It captures insulin resistance and diabetes, and it captures, you guessed it, obesity. So metabolic syndrome is this term that we use because for all these illnesses that when you consider that what they have in common, they have essentially you got problems in how you're metabolizing fuel for your body. And really that problem is coming from a place of having too much fuel and often not good quality fuel. I do like to think of the car as I do like to think of the body as a bit of a car. You know, if you put in good quality petrol and you run it well, then the engine will run nicely. If you put crap quality fuel and there's too much, I guess that analogy falls through because that's not how cars work. But yeah, if you have too much fuel, then the metabolism of that fuel will go awry. You will get metabolic syndrome issues. So let's talk about obesity. I mean, it's characterized really by BMI. What a terrible definition, by the way. I mean, technically, okay, what is BMI? BMI is your height, your weight divided by your height squared. You can use an online. So I got the sniffles. I was camping and I breathed in a lot of dust, and now I've been coughing up dust. So please excuse me. But I got my lemon and ginger tea. Anyway, BMI. So it's your height. It's a kind of calculator based on height and weight, and it's very bad in my opinion because it doesn't take into account biocomposition. What do I mean by that? It doesn't take into account what percentage of your body is muscle, is fat, is water, is bone. You know, so someone who's quite fit and muscular could be considered overweight. In some cases, maybe even obese, because they might weigh a lot because they are largely muscular, but wouldn't be considered, having metabolic syndrome or that's not technically unhealthy. It's just the weight of their body makes them go into this range that they're considered overweight or obese in. So it's important to consider biocomposition when you can. The issue with that is that it costs more and it's harder to do. So you need to get a DEXA scan, you need to do blood tests. So it can be a bit more tricky. And so BMI is preferred when we're talking about population information. So, if we're to talk about what percentage of Australians are overweight or obese, have a guess. I mean, it's 2/3, 66% are overweight or obese. Okay, not just obese, overweight or obese. So lesser obese. But if you then consider what percentage of people who are on antipsychotics are overweight or obese, it's 80%. Okay, so pushes the numbers up even more. And so we're going to talk about why these drugs and these illnesses together can really increase the risk of obesity. But most importantly, we're going to talk about what we can do about it. So why does someone become overweight? It is as simple and it isn't as simple as calories in versus calories out. So if you have a surplus of calories, they will be stored as fat, simply put. But that's not that helpful a way to think about obesity, because you really want to know, why is there being a surplus of calories in? That's the interesting question. And it's multifactorial. In psychiatry, we always use a biopsychosocial approach, and cultural as well, and spiritual too sometimes. So these are the kind of different categories we use to address problems. But the biological kind of set of factors, that's things like evolution. We are driven to eat to store fat because that would increase our survival as animals when we were in a resource scarce environment when there wasn't that much food around. But we are the first animal to really change the environment to suit our needs rather than to change our needs to suit the environment, which is the whole philosophy of survival of the fittest. We've changed the environment to fit our needs. Now there's a surplus of calories around, and we still have the same genes, we still have the same drives to eat and hold on to food, but there's so much more food everywhere. And so, we definitely eat too much. And there's all these biological mechanisms to make sure we eat a surplus. Like if you stub your toe, you know your toe hurts like that. It hurts straight away. Maybe a 1 second delay when you feel the boom, and then you're like, oh, here comes the pain, and then boom, here comes the pain, hits you. But when you are full, when your tummy is full of food, it takes 20 minutes, 20 minutes to feel full. Okay, it takes, it's kind of sadistic. It would be way more efficient if you knew straight away you were full and you could just stop eating, but that's not how it works. So there's all these biological hormone systems around orexin, leptin, and ghrelin. These are the hormones involved in the balances that are, that play on your brain, and then you have. Oh, we don't have to go into neurobiology for this video. If people are interested in the neurobiology, put a comment down below. We can geek out. But that's all the biological stuff. There's also psychological stuff, right? Like it does make you feel better when you eat whilst you're eating, not after. No, not after. But when you're stressed, I stress eat. I stress eat, and also if I'm doing night shifts, when I'm tired, I'll overeat. I'll eat chocolates, and I'll have this craving for unhealthy food. So, and it makes me feel better. So, depending on your mood and your stresses, that's the psychological component to eating. And then there's the sociocultural, right? We food is this big thing. There are cooking channels. There are, we gather around meals to catch up. We get dinner, and not only that, but we use food as rewards as well. We give chocolate. We give chocolate when your kid does a good job. That kind of thing. Like I'm not saying it's good or bad, but it's worth noting as all these things piece together to make a bit of an issue, well, to result in more calories going in than out. Okay. um, uh, we didn't really talk about the quality of calories, but the type of calories you eat is also very, very important in how your body digests them. So that's kind of why. That's the big why. But now when we think about medications, and really it's antidepressants and antipsychotics, these second generation antipsychotics, there's really a significant association with weight gain. And so when we start someone on an antipsychotic, as a doctor and talking with a patient, we always have to decide, are the benefits outweighing the risks? Okay. And if someone has a schizophrenia and they have issues in reality testing and knowing what's real, what's not real, and they're doing high risk things like running across the street, or jumping off buildings because they think they can fly, or attacking someone because they felt they were being followed, then obviously in those cases the risk of the medications and the associated weight gain is worth the treatment of a psychosis that's making someone being put in a life-threatening situation because of the risks of their illness. Now, that's the simple thing, but most people it's not that simple. There's often the grey area in between, and you have to negotiate and think about it. And there are things that we can do to reduce the amount of weight gain with these drugs, but really the statistics are pretty clear. So there was two big trials in the 2000s, and really I won't go through all the numbers here that I've got, but I can tell you that within 3 months you're getting 5 to 10 kilograms of weight gain with some of these second generation antipsychotics. The ones to be careful of are olanzapine, clozapine, quetiapine, risperidone a little bit less, but still there. Ziprasidone a little bit. These are the second generation antipsychotics associated with weight gain. The mechanism of which they cause weight gain is interesting, and not fully understood. There's issues in the histamine receptor system, and yes, you might think histamine, allergies. Why are we talking about weight gain? Well, because in the body, the histamine receptors work very differently to the brain. Histamine in the brain is very important in alertness and circadian rhythms and appetite. So if you've got antihistamines on board, even if you're eating, you don't feel full. You just keep eating. And there is a direct effect of some of these antipsychotics on those hormones we talked about before, the ghrelin, leptin balance, and olanzapine, for example, does directly inhibit ghrelin. So people feel hungrier for longer, and so overeat, and specifically with a drive for carbohydrates. So it's really, when you look at what people are eating when they're on antipsychotics, it's much higher levels of carbohydrates. Okay, so now let's talk a bit about what to do about this global problem. Because, this is a video about being overweight and obese, suffering from obesity in psychiatric situations, people on antidepressants or antipsychotics. But this is a problem for, it can affect anyone. It's not just people on medications. So, we talk about diet and exercise, and it's kind of minimized now because it's just improved diet and exercise, yada, yada, yada. But people don't really talk about what that means. Like, what does that actually mean? So it does work, okay? It's sometimes not sufficient in and of itself, and it's sometimes really hard, especially if the illness or a side effect of the medications is anhedonia or amotivation. So in people with depression or prodromal psychosis, they might have issues even getting out of bed, even having a shower, even doing things. So very hard to motivate someone to do something when they're not motivated to do anything. And sometimes the motivation issue is it's biological, right? The part of the brain, the prefrontal cortex, the dorsolateral prefrontal cortex that coordinates the rest of the brain and drives behavior into different directions, and the mesolimbic circuit, which stimulates people towards rewarding and meaningful activities. These circuits are very dysfunctional in psychosis. So, this is the theory, the dopaminergic theory of psychosis, and why we think certain, that it happens. But it's dysfunctional. They're not driven biologically to the same way other people are. But anyway, it's still important to go through this advice, so at least that the information is there. And when we talk about diet stuff, there's a lot of don'ts and there's a lot of do's. The don't stuff is cut out the crap food, right? When you minimize it once a day, maybe once every 2 days if you can. But sugary drinks, high trans fats, things like butter and chocolate, all the good stuff. It's good for a reason, but every time I kind of indulge, a part of me does say you got to die 5 minutes earlier for this. That's how I tell myself about it. I'm pretty, confronting with it. But then there's what you should do as well. So cut out the crap stuff, but include the good stuff. So a good plate includes a lot of healthy protein, chicken, lean meats, and if you're vegetarian, you should look into vegetarian high protein foods. A lot of vegetables, right? There's a reason the Mediterranean diet is associated with longevity. It's the vegetables. So many vegetables and olive oil. That stuff's great. So it's also very filling when you just buff up a meal with a lot of vegetables. If you chuck some spices on the vegetables, it's pretty good. Like one of my go-to lunches is kangaroo and veggies. And if I overload the veggies, I actually don't need any other carbs. I don't need any rice or noodles or anything. Just the veggies will fill me up. Other tips around eating can include being more mindful with eating, making sure you're not on your phone, watching TV and watching this YouTube video. Just eat. Focus on the food, focus on the textures in your mouth. When you're more mindful and more in touch with your body, first of all, you're happier in life in general, but also you slow things down. One of my life hacks, I don't know if this isn't backed by the WHO or anything, but I try and put spicy stuff in my food because I don't like spicy stuff. But when it's spicy, I eat slower. So sushi, smash that with wasabi and you won't eat too quickly because your face will explode. So find systems that work for you. It's by no means easy, but I think meal prepping is another really key thing that's helpful that I do as well, and that I think a lot of healthy people do. Because the second you don't have, I think essentially healthy food takes longer to prepare, right? When things are processed and pre-prepared and yummy, you can go and you grab them quickly and it's great, it's easy, but it's not good for you. But when you bulk prep some salads, I've got in the fridge right now, I've got some tuna salads and I've got some garden salads and I've got some yogurt muesli, blueberry mixes. I've got all these meals. I made a video actually about the meals I eat in a day. You can check that out if you want. But if you bulk prep all your meals, then it's as easy to just get a spoon and a salad as it is to get a Kit Kat. It's not as good. Although sometimes you'd be surprised how good like a nice cold crispy garden salad is. Like it actually you start to look forward to it. Like I actually like it now, but it took a little while. I'm going through the official advice on healthy diets, and you guys can Google all this. But really, it's around reducing the sugary drinks and eating slower and going for healthier choices, which we spoke all about. Now, having a high protein diet is really good, but it's a little bit like, what's the point if you're not doing any exercise? And exercise is absolutely critical for longevity. Look, here's the thing. If you want to reduce the number on a scale, if you want to lose weight, really diet is the way to go. Like reducing caloric intake, because increasing exercise doesn't have the same effect on losing overall weight. But if your goal is to live longer, healthier, and more disease free, then really exercise is the key metric. Ideally it's both, right? But someone who's exercising every day with an average to below average diet will tend to live longer than someone with a great diet but that does no exercise. Okay, so exercise is critical for longevity, diet is critical for losing weight. Really what we want is both. And what do we mean by exercise? Well, I could talk hours for this, and maybe I should make a video just about exercise. But a good exercise routine includes intense. It includes 4 pillars, as per Peter Attia. So the 4 pillars. Pillar number 1 is aerobic. Okay, this is endurance, also known as zone 2. This is the kind of exercise where you don't want to be chatting, but you can chat if you need to, and you can hold a conversation, but it ain't enjoyable. You don't want to be sitting there talking about life. You take the phone call and you're talking and you want it to end. So it's a light to moderate jog, or you can do it on a bike, and it's a zone 2 heart rate, so it's the 130s of your heart rate, and you want to do this, getting towards 3 hours a week, ideally, in the perfect world. These are the ideals, right? When you start off, 20 minutes is fine. When you're starting, there is no amount that is too little, okay? There's no such thing as too little. Just doing it is a great start if you haven't been doing it before. That's really important to know. And when I'm feeling like crap, or if I'm a bit sick, or if I'm, just haven't slept well, if I'm not in the zone, I'll just do a short workout, because there's no such thing as too little if the alternative is not doing anything at all, okay? Even 5 minutes is better than nothing. So more is always better, to a point. So that's the aerobic stuff. That's the cardio, right? Got to do your cardio, as Sam Sulek says. Then the second pillar is anaerobic. This is the higher intensity stuff. And really it's kind of sprints in a way. And this is much harder, and if you're not up to it yet, that's fine. You can bring it in later in your exercise journey. And usually it's 4 minutes on, 4 minutes off 4 times. That's called like the Scandinavian protocol or something. And that when people did that for 2 years, a couple times a week, the study's a bit more complicated than that. But anyway, roughly speaking, when people do that, their heart health reverses by decades. So it was 50-year-olds in that study, and by the end of the study, their hearts were 15 to 20 years younger in terms of their structure and their function. So really, really good to do anaerobic exercise. I personally hate it. I do it once a week, and it's miserable. But I just start slow. I don't do. I start with 2 minutes on, 2 minutes off, and do that 4 times, and I'm building up to 4 minutes on, 4 minutes off. So start wherever it's realistic for you. So that's the first 2 pillars, anaerobic and aerobic, although I said them in the reverse order. The next pillar is stability, right? So this is balance. This is stability is a complex thing. It's a catch-all term that's just all the odd exercises. So being able to balance on one leg and doing a squat with one foot, and also flexibility. So it's strength through flexibility. The whole goal of stability is to reduce kind of frailty and falls, really. And so that's really important, especially to avoid injuries and arthritis and all those kind of things, to do stability workouts. And it also involves core. So I usually do a bit of core, a bit of stretching, and all sorts of things. If you want to get specific workout protocols, you can Google Peter Attia and type in like his stability routine and that kind of thing. And the fourth and final pillar is strength. Getting weights, muscle. So obviously no one needs to be a bodybuilder here, but you want to do weight-based exercises. It can be body weight, but the more muscle you have on your body to a point, right? I'm talking healthy, non-testosterone muscle. I'm not talking about like doing steroids and becoming a muscle bloody bodybuilder. I'm talking just getting strong. Having good muscle mass is proportional to having a longer health span. Okay, and after the age of 50, people tend to lose muscle. So you want to kind of build as much muscle as you can, and then after 50, it gets harder to build muscle. So important to include strength exercise as part of people's exercise routine. Now, if you are gaining weight on antipsychotics and you've been trying the diet and exercise advice that we've kind of talked about, there are things that we can do medication-wise to help with weight gain, and you need to talk to your psychiatrist or GP about this. This isn't medical advice. This is just for your information and to give you some things to talk about when you see your doctor. But there are drugs out there that are associated with weight loss. The most common and most evidence-based one in terms of weight gain associated with antipsychotics and antidepressants is metformin. Now, this is a drug used in diabetes. It's an insulin sensitizer in a way, and it also has central effects on the liver and its glucose metabolism. But it's associated with weight loss. It's a pretty complicated drug in how it works. I haven't met anyone who fully gets it, and I think it's incompletely understood. But essentially, it just means that your peripheral cells use glucose more effectively. So if you have high levels of glucose in your blood, your peripheral cells are using it more efficiently, and so it's not getting stored as fat, it's getting metabolized, which is a good thing. Also reduces the amount of glucose that your liver is pumping out, so it helps on that front as well. And it does help people get a modest weight loss effect. If you're taking metformin and you're still eating Macca's twice a day, it's not going to do much, and you need to kind of be careful how you start it, because it does cause a bit of irritation in the gut. It causes a lot of nausea for some people, so you need to start it with food, low dose, and build up over time the dose, and talk to your doctors about that. It's not appropriate for everyone. There are contraindications, so it's not. And it's not like a Hail Mary that you just lose all the weight. It's a modest effect. So please keep that in mind. Another kind of drug that's coming to the front of the attention in the media, and it's a whole thing because they're running out of stock because people without obesity are using it to keep weight off or to lose extra weight. It's called Ozempic. It's a GLP-1 agonist. GLP-1's a very interesting hormone. It has effects everywhere in the body. It's very important in appetite and in your gut mobility and motility, so how fast it moves food through your gut. It has effects on muscle cells, fat cells, pancreas, in your heart. I'm just going through the list here, but it's a hormone, GLP-1, that affects your whole body. But the most important things is it makes you feel well. When you have high levels of GLP-1, it reduces appetite and reduces the speed of food going through your tummy and increases the efficiency of cells in your muscles and your fats of metabolizing glucose. And all that together results in weight loss and eating less total. You eat less food because you're feeling fuller quicker and the food's sitting in your tummy for a bit longer. So you feel full and you eat less. And people get pretty good weight loss on this. So talk to your doctor about whether it's appropriate for you. It's still not a miracle cure. It's in the order of 3 to 4 kilograms in 3 to 4 months. But that's something. And if you mix it with a healthy diet and exercise, you get very good outcomes. Some of the more recent research is showing that there's a bit of muscle loss with this as well. So you need to be careful if you have, like, you want to protect as much muscle as you can. So you have to consider the pros and cons of that with your doctor. Now, there's a lot of other drugs that aren't as commonly used. There's bupropion, which can be mixed with naltrexone. I forgot what that's called. It's used in the States for weight loss. There's orlistat, which stops your absorption of fats, which means your poo can become very fatty. You get very fatty poos, which are hard to flush and look terrible, and smell bad. But you absorb less fat and you do lose weight. And so you have to think about the pros and cons of that. And topiramate is another one. Topiramate is used usually in mood regulation. It's been used in epilepsy. I don't know how effective it is. It's not the most impressive anticonvulsant, but has been shown to have some weight loss associated with it. Side effects with topiramate, you've got to be careful, is it does tend to cause some, let's call it cognitive fuzzying. There might be some IQ, it might lower some IQ, it might cause some confusion, cause problems in word finding, and so it's not appropriate for everyone. But hey, I think you've got to be open to trying. I think the thing is, complex problems have complex solutions. So you need to talk to your doctor about all these options, find out what the right cocktail is for you. It is like a cocktail. There's the base, and there's all the different ingredients you can add to it. The base is exercise and diet. Those are core, and everyone has to do them. And the extra ingredients you can sprinkle on. It might include medications and other strategies that you can work on with your doctor. But that is everything I wanted to talk about. The last thing to say is that if someone is got a BMI over 35 and diabetes or obese, and other weight affected comorbidities like high blood pressure or diabetes, then you can be considered for bariatric surgery, like a gastric sleeve or gastric band. They used to do bands more. Now they don't really do bands anymore because the bands tend to slip. So it's usually gastric sleeve is the most common one. But a bariatric surgery is essentially when a surgeon makes your tummy smaller by cutting it up, and that just makes you feel fuller quicker, obviously, and eat less food. And it's definitely associated with weight loss. But it's an intense surgery. There's intense follow-up and recovery, and you need to be able to engage in the post-operative healthy eating plan and work with physiotherapists and dietitians to make sure that you're doing the right things. So it's someone who's unstable because of their mental state, it might not be right for them because they might not be able to attend appointments if life's a bit chaotic and things like that. So it's not for everyone, but it's good to know that is an option as well. And that's it. Look, the other thing to say is every 5 years, there's usually a new weight loss drug, and they're getting better and better. Okay, so at the moment, there's one in development. There's probably many in the development, but just watch this space. Okay, in the next 50 years, there'll be more and more drugs. There's more and more hope. But just do your best to eat well and do exercise, and then talk to your doctors about metformin, ozempic, and these options. And leave your comments down below with your stories as well. If there's something that has worked for you, put it in the comments below so other people can read it, so I can read it. This is a problem that affects everyone. Everyone. Well, not some people don't eat enough, but it affects a lot of people, and it's hard. And together we can try and get on top of it. But it's tricky. It's really, really hard. That's it for this video, guys. Lots of love. Wish you all a beautiful day. Call a friend. Tell them you love them. Good stuff. And I'll see you in the next one. All right. Bye for now.